Welcome, everyone. Thank you for attending my session. SBIRT is harm reduction. My name is Chris Hall. I'm the program manager for the Center for Excellence in Collaborative Education, and as well as the SBIRT grant received by UNE about 4 years ago. I have no conflicts to disclose in this presentation. The grant I mentioned was from the Substance Abuse and Mental Health Services Administration. We don't use the term abuse anymore. We wouldn't use that for someone with a chronic disease, and so we don't use it for this one. But we trained health profession students from 8 and sometimes 9 different health professions about SBIRT, which is a screening tool. And we approached it this way because at UNE, we believe that collaborative care is the best care, and also because we believe that intervention can occur in even the briefest encounter with a sensitive, caring, and professional healthcare provider, any provider. So SBIRT stands for Screening, Brief Intervention, and Referral for Treatment. Screening is recommended to be universal, and regardless of what healthcare profession you have studied or you are currently practicing, you do some kind of screening. So this is no different than the screening that you already do. Brief intervention is a conversation, and I'll explain how that can work. And referral to treatment is something that you already do when something is outside of your scope of practice, and this is no different. You know that the most successful referrals are ones that you make to other providers that you have an existing relationship with, and this is no different than that. We argue that all aspects of the healthcare system own SBIRT, own aspects of the screening, intervention, and treatment. And SBIRT is preventative as well as harm reduction in the moment. And so it has a fiscal benefit. It has obviously a health benefit. And some health providers have more time with patients than others do. Dental hygiene, for example, if you have health insurance and are using it, then you can see your dental hygienist every 6 months, and they're going to know you really well and have time to have that conversation. Physical therapists have a lot of time with their patients. At the end of this session, I hope that you'll be able to demonstrate awareness of the SBIRT model and identify resources to incorporate it into your personal practice or into your systemic practice. The reason that I argue that SBIRT is a harm reduction tool because as a screening tool, its use is to triage risk. And harm reduction is all about triaging risk. What is the risk of the behavior and how can we reduce that risk? The brief intervention is a conversation that allows you to educate about the risk of use. And all healthcare providers are educators. You're always educating your patients about how they can change their behavior or try something new to reach their goals. Harm reduction is based in unconditional regard, as any healthcare should be. You need to meet people where they're at. It's not about your prejudgment. It's not about the last patient you saw. It's unconditional regard. And you want to engage with people early. That's the preventative aspect of it. You want to engage with them often. That's a harm reduction aspect. You want to be checking in on people's risky use, and you want to be educating them about it every time you see them, so they recognize that you're going to bring up the conversation. And any health professional can do this. In fact, it doesn't matter what your training is. To a certain extent, you can do this. And of course, referral for treatment should reflect that all roads can lead to recovery. This is not abstinence-based. The evidence for SBIRT is that when used properly and consistently, it can result in reductions in alcohol and drug use 6 months after the intervention. SBIRT, I think, was designed particularly for alcohol, but the steps can be used for any intervention. quality of life measures improve, and reductions in emergency room visits. So that's obviously good for the patient or client, but it also has an enormous fiscal benefit as well. So we know if you're here at the Harm Reduction Conference, you probably know that substance use disorder is a chronic disease, and it is because the reward system in the brain has been hijacked. So we treat it like any other chronic disease. There is no cure for substance use disorder, like there's no cure for asthma or diabetes or heart disease. You treat it, you manage it. But for substances, if you pick them up again, you will be addicted to them again. And so it's a lifelong practice. It's treatable, it can be managed, and there are different treatment approaches, and medication-assisted treatment is consistently the most effective. So harm reduction starts with you. It starts with the attitude that you go into every encounter with. So what do you bring to the interaction? What are your preconceptions? What is your experience? What are you willing to discuss or hear on this patient's path to recovery? So unwavering compassion and regard is hard to maintain sometimes, but it's necessary. This person has not done anything wrong, just like the person with diabetes or a heart condition has not done anything wrong. The person is not weak. It's not because they can't make better choices. It's a chronic condition. This person is not a loser. They are sick, they are afraid, and they are afraid of being judged. Stigma is an enormous part of the cycle of addiction, and stigma should not be something that they find in an encounter with a healthcare provider. So why you? Why you as a healthcare provider, and why isn't it the job of the family to address addiction? Is it the job of the family to address diabetes? Is it the job of the family to address chronic heart problems? Yes, they can help. Yes, they can be supportive. Yes, they can be educated. And yes, they can help to maintain the treatment path and the maintenance of whatever the patient is trying to achieve. But also, with the family, as you know, if you think about family members that you may have who may be struggling with some kind of substance use disorder, what is that conversation going to be like if the family sits them down? I mean, it's going to be highly charged, very emotional, fraught with blame, guilt. Like, it's a very complicated situation that doesn't happen in the healthcare provider's office. You are a professional, you are an expert, you are a respected person outside the family, and if you bring it up in a non-judgmental way and engage them in a conversation that you're comfortable having and that makes them comfortable having, then that's a great way to establish trust and rapport. So with a primary care doctor, with an occupational therapist, with a dental hygienist, everybody can be part of having this conversation. You don't have to be an expert in addiction to have a quick conversation about it. So, like I said before, we recommend universal screening. This particular diagram is based on alcohol. And so most people have low or no use, low or no risk. And at that point, when you screen them, you can reinforce that. You can say, this is great. I'm not concerned about your health due to the alcohol that you're drinking. And so let's move on to something else. It can take a very short amount of time. Some percentage, 20% or so, may have risky behavior. And that's where the harm reduction comes in, because you can talk to them about that risky behavior. So you're catching it before it becomes extreme, and you're normalizing the conversation about it. And no one else in their life may ever have had that conversation with them. And so as a healthcare provider, that's your bailiwick. And then some smaller percentage, 7, 10, 15% at the most, depending upon your practice area and your patient panel, will require a referral to treatment. And so those are the people that you would spend the most time on for this issue. But everyone else is it's possible to manage very quickly. So basic steps in screening is to introduce the screen, be specific in your questions, make sure you are speaking the same language as the patient, and to probe and use reflective listening to make sure that you understand what they're saying. And again, a non-judgmental attitude throughout the screen, no matter what the answers are. So if you're screening someone for drug use, you can say, what is it about heroin that you like? I mean, there was maybe something at the beginning, or there's nothing, but it gives them a chance to talk about it out loud. What is it about drinking that you like? Be ready to have that conversation and hear those answers. Some of the tools, the audit is the primary tool, asking how often you have a drink, and then you are able to score it. And based on those scores, you'll know where they are on the risk level and be able to have a conversation after that. The DAST is a drug and alcohol screen. Again, it's a conversation. You're just asking, trying to triage their risk. What is their level of risk? There's a specific tool for teenagers and pregnant women. These tools have been validated to have a high percentage of accuracy in terms of determining a person's risk. And here is one of many tools that you can use. It's a pocket card that you can have handy as you go through the tool and determine the score, and then think about what to do next. So on the audit, if they score 20 plus, then they're at high risk for substance use disorder. And if then you would refer to treatment. That would be your next step. 16 to 19 is harmful risk, so that you can talk to someone, briefly intervene with them. Risky use is really where you want to catch people so that you can normalize the conversation. And low risk is a way to just reinforce the healthy choices that people are making. The referral resources, obviously 211, which I'll talk about a little bit later, and SAMHSA has an enormous number of resources. The Readiness Ruler is a motivational interviewing tool, which I'll talk about in just a minute. So for talking points, which are often helpful, you raise the subject, ask permission to talk about it, and say, is it okay if we review your results? Provide feedback based on the level of risk that you're seeing and what you know their health implications are for the use that they're experiencing. Find their motivation to use and their motivation to stop using, and use the Readiness Ruler, which is on the bottom here. And then negotiate a plan. And if their plan is they don't want to do anything, then you can say, well, I'm going to see you again in X number of months. I'm probably going to bring it up again. Is that all right? So that they're thinking about it. It's working in the background when they're not with you. And this is another way of stepping through the brief negotiated interview. As an educator, which all healthcare providers are educators, you can educate yourself about what addiction does to the body and the brain. And if you are talking to someone with an elevated level of risk, you can talk to them about liver damage. You can talk to them about falling. You can talk to them about memory loss. It's all going to be specific to that particular patient. What is it that they're concerned about, and how is their use likely to make the concerning condition worse? I mentioned motivational interviewing, and it's a conversation style for strengthening a person's own motivation and commitment for change. So this is evidence-based way of conducting a quick clinical conversation that enhances motivation. The folks who put it together, Rolnick, Miller, and Butler, hold that no person is completely unmotivated. And especially in a healthcare setting, they're there because they perceive that something is wrong. And so they are motivated to correct whatever it is that they perceive as wrong. Motivational interviewing can be used for all different things, not substance use disorder exclusively. Smoking, weight issues, alcohol, and there that word abuse has showed up in my slides again. I apologize for that. Chronic pain, and we know that there's a real connection between chronic pain and opioid use disorder, and motivational interviewing can play a role in there. So it has an effect on body mass, cholesterol, blood pressure. Motivational interviewing as a tool outperforms traditional advice giving. So rather than saying, well, you really should do this, you're asking an open-ended question about what they would like to achieve. And that is good for patient care, and it's good for talking to your spouse about why they don't take the trash out. Same thing, anybody can do it. Even a brief encounter, and it has to be brief, right? Because you don't have a ton of time with people most of the time, so you have to be able to get through it. Control the conversation in such a way that you're moving toward the patient or client's goal very quickly. And it's not related to the provider's educational background. Once you learn motivational interviewing, you can use it. You can use it with anyone. Client-centered, compassionate, as I've mentioned before, and it's about lifestyle change. What you're exploring is ambivalence. So they're there because they perceive that something is wrong and they may want to change it, but they may be ambivalent about their ability to change it. And so what you do with motivational interviewing is you elicit change talk. Foundations are respect, and the belief that the client is the expert about their own life, which we all like to think we're experts about our own life. Evidence-based way to promote health. So I'm not going to teach you about MI today. That's the lifelong practice, but there are plenty of resources that I can share with you that can get you into a training of some kind. So how will you use motivational interviewing? There's one part of it has to do with your personal behaviors as a practitioner. How are you willing to have these conversations and hear these answers? And the other part has to do with your practice's systems. So for you, it's all about creating the relationship. What you always want to do is make sure that your patient comes back for their next appointment. So you develop the relationship and establish trust. You don't want to write it, right? You want them to think about how and what they would like to change. You want to be empathetic and compassionate. You want to create, draw out, highlight the ambivalence that they're feeling about, can I do this? Do I want to do it? How much do I want to do it? You want to listen to them in a way that they may have never been listened to. You don't have to fix it. You just have to help them understand what they want to do to fix it, and then you can provide resources, and you want to support that self-efficacy. As far as your organization goes, there are some steps to take in order to begin to use this consistently across your organization. And so what you want to do is look at your patient panel and figure out what the percentage of adults and teens you're seeing who are getting screened now. It should be 100%. And then based on the averages of people who are experiencing substance use disorder, you can sort of distill how many people you're likely to be seeing who are at risk or increased risk. I know for dental hygiene, based on the percentage of people experiencing substance use disorders, you can confidently say that at least 2 people a week are going to be at a higher risk. And so if you know those people are coming to your practice and you know you're going to have half an hour 45 minutes with them as the dental hygienist, then you want to establish some way to have that conversation as part of the screening you do for everyone. And then you can start to develop a relationship and a norm and the capacity to have the conversation. And people will look forward to it, and people are happy to talk about it by and large when screened about their willingness to discuss risky use of substances. People are 90% or more of people are happy to talk about it. The only topic that they're having a hard time finding a good screening question for is the use, is whether or not there are guns in the home. That's, people don't want to talk about that, but substance use, they're happy to talk about, especially because they're there with you. You're an expert, um, you're an authority figure, and you're not a family member. And so they're happy to have this conversation with you. And that can increase your confidence in broaching the subject and having the conversation. And is your system, is your office ready to implement SBIRT? I think that understanding the follow-on benefits of the reduced readmissions or overall health of your patient panel has a fiscal aspect to it, which makes it worthwhile. So what do you need in order to talk to your system or your office about making sure that you're implementing SBIRT screening for everyone? So here's a sample workflow of ways that you can manage working SBIRT into something that everyone does. You can institute a wellness survey for everyone who comes in, and that can have some screening questions in it. And then you move on from the self-screen to the conversation with a medical provider or health provider. And then you can establish a relationship with behavioral health if you don't have them on site, so that if someone needs to be referred for treatment, you can do so, but you just need to establish that workflow. Again, it can, another example is that it can start with the receptionist if it's not a digital self-screen, or a medical assistant can deploy the screening part of it, and then moving to a provider and then to behavioral health. For some organizations, they have behavioral health on staff who have a third of an hour unscheduled every hour. And so if someone is in a meeting, a patient encounter, and they realize that they could benefit from a warm handoff to have that conversation, then there's always a behavioral health person who's available to immediately be introduced via a warm handoff, which is the best way to do it. You can be reimbursed for SBIRT. Medicare obviously has a lot, but commercial insurance can cover it as well. And so your system would want to look into what those codes are and how they can work it into the billing so that that time is accounted for. But remember, for most people, specifically with alcohol, most people, it's very quick that you're just reinforcing their good behavior. And for the smaller percentage of people who need more time, you can set up systems to give them more time. There are many, many, many resources on the web. Maine's Quality Counts has some great resources. The Opportunity Alliance has some great resources. There are a lot of people whose pocket cards you can just ask for on the internet, and they will mail you a pocket card. There are national resources, obviously. The Oregon SBIRT grant has a great web page, and SAMHSA, HRSA, Center for Integrated Health Solutions, has some great information. As far as Maine is concerned, 211 is a resource. It's a place to start where you can call 211 and they will help you find referral resources, just like they'll help you find, heating assistance and all of the things that 211 provides referral and resources for. 211, last I knew, also has the ability to text with moms experiencing substance use disorder and to help a little bit more than usual with referrals, which is great. But 211 is only as good as their database. And the database, you have to submit your organization to their database, otherwise it doesn't show up. And so if you're offering any of these services, you want to contact 211 and make sure you're in their database so that they can then offer your information to people who are looking for it. A little bit of a backwards system there. And obviously Maine.gov has made quite a commitment to substance use disorder with the Office for Opioid Response and the work that Gordon Smith is doing, and the opioid conference in the summer, which is great. So universal screening is realistic in multiple medical and community settings. You just need to look at it from a systems point of view and figure out what you need to do to set it up. It's definitely worthwhile. And the tools, the brief interview and the motivational interviewing can improve practice overall because they're respectful, person-centered skills. But it is a lifelong learning process, and you just have to sort of jump in there and get some training and use it consistently. And there are many resources available. And there's that word abuse again in my slides. So again, I think that SBIRT is a harm reduction tool. You're triaging risk, you're educating about risk, you're approaching with unconditional regard every time you interact with a patient or your patient interacts with any kind of health professional. And then all roads can lead to recovery. So if you're not ready now, if the patient's not ready now, then you'll talk to them next time. But you're always going to be a safe and non-stigmatizing person to bring the issue up with. And so you're certainly welcome to keep in touch and reach out to us if you have any questions about our program or anything else SBIRT related, and we would be happy to help. Thanks very much and have a terrific day.